Buenas tardes, bienvenidos al seminario virtual de la Comisión de Endoscopía Flexible de la Asociación Argentina de Cirugía en conjunto con el Comité de Videoendoscopía, de Cirugía Videoendoscópica y de Cirugía Mininvasiva. Contamos con la presencia, con el honor de tenerlo presente al doctor Jelle Ruurda y al doctor Felix Berlth. El doctor Jelle Ruurda de Holanda, ya lo vamos a presentar, y el doctor Felix Berlth de Alemania. Junto conmigo el doctor Maximiliano Loviseck, Alejandro Nieponice como presentador y Mauricio Ramirez, el doctor Fernando Wright y los panelistas Matias y el doctor Javier Iturralde Algerich. Bueno, el título para hoy es Esofagectomía Mininvasiva y la resolución endoscópica de sus complicaciones. La modalidad que vamos a tener, Alejandro va a presentarnos el caso clínico y de ahí se va a ir desarrollando en conjunto con los doctores Jelle Ruurda y el doctor Felix Berlth. Bueno, el doctor Jelle Ruurda es chairman de la Universidad, del Centro Médico de la Universidad de Utrecht, es chairman de cirugía robótica, un experto en la temática y en cirugía de esófago. El doctor Felix Berlth es cirujano y endoscopista del Centro Médico del Medical Center de la Universidad de Mainz en Alemania, así que también un honor contar con su presencia para el desarrollo del caso que tenemos hoy. Bueno, adelante Ale, si podemos comenzar.
Gracias Alfredo y gracias nuevamente tanto a los participantes nacionales, panelistas, directores, como a los dos conferencistas internacionales con quien tenemos el orgullo de contar hoy. Y como saben, tratamos siempre de darle una dinámica diferente a la forma de exponer y tratamos de usar los casos clínicos como disparadores, así que van a ver que los oradores por ahí van a saltar entre diapositiva y diapositiva para contestar las preguntas que vamos haciendo y que le van a hacer los panelistas luego. Entonces vamos a empezar con este caso de una señora de 65 años que comienza con disfagia y pérdida de peso, y cuando se le hace la endoscopía se detecta una lesión del tercio inferior de esófago que tiene todo el aspecto de ser infiltrativa, que en la ecoendoscopía corrobora como un T2, y que en la histología es un adenocarcinoma de tipo intestinal bien diferenciado. La primera pregunta para hacerle a Jelle es, en estos casos puntuales que están en el límite en un T2, ¿cuándo hacen neoadjuvancia y cuándo no? Y qué tipo de neoadjuvancia eligen para estos tumores que son bien de estirpe esofágica, de la unión, pero Ciber 1.
Yeah, I think you bring up a good point there, Alex. The thing is with T2s is that you're never sure if they're really T2s. And we looked into our nationwide database, and I think about 80% were upstaged to T3. So I think in a true T2, you might do surgery alone. I think that there's good evidence to do primary surgery, but if you have the slightest suspicion of it being a T3, I would go for neoadjuvant treatment. And there's a lot of debate on what you choose. And to be frank, it's not sorted out. And it's chemo versus chemoradiotherapy. And I'm actually more and more a fan of chemotherapy rather than chemoradiotherapy. I think chemoradiography is very nice if you have a bulky tumor. It really reduces the size of the tumor. And if it's marginally resectable, you will scale it down and you'll make it resectable. It's pretty similar to a rectal carcinoma, to my opinion. If you have an involved circumferential resection margin, you would go for chemoradiotherapy. And if not, you can do with less neoadjuvant treatments or more systemic neoadjuvant treatments. So I think it's a balanced discussion. We're not completely sure. Traditionally, in my center, such a tumor would get chemoradiotherapy.
Would you do cross in there?
Cross, yeah. And I think for squamous, without a doubt, for an adenocarcinoma, cross would still be it. But I'm more and more going in the direction that I would do FLOT rather than cross.
Mm-hmm.
Two trials running right now. One just finished in Ireland and the UK. John Reynolds was the PI, or is the PI of that trial. And I heard the results on a conference, and there were no differences in survival or whatever. But toxicity was a bit more severe with cross in that trial. And there's another one, and I'm pretty sure that that Felix can tell you a bit more about it because it's recruiting in Germany right now. It's one of the FLOT trials that is head-to-head comparing FLOT to cross right now.
Bien. Bueno, seguro ahora cuando empiece la discusión con los panelistas este tema va a volver a estar. Queríamos introducirlo para que después sirva en la discusión, pero vamos a avanzar con la parte quirúrgica, así mantenemos dentro del timing. Nosotros efectivamente hacemos también neoadjuvancia en la mayoría de los tumores T2 porque coincidimos en que la mayoría son T3 y en los casos de esófago hacemos el régimen de cross, pero también estamos evaluando mucho la posibilidad de FLOT. En este caso, el paciente se hizo quimiorradioterapia cross tradicional, mejoría franca en la disfagia, comenzó a recuperar peso y una clara respuesta clínica y por imágenes en el PET scan. Perdón, ahí esto es para otro. Ahí va. A este paciente nosotros lo enviamos a cirugía y Ela creo que vos también, así que te invitamos a mostrarnos qué es lo que haces en Utrecht cada vez que tenés un paciente con cross que respondió bien al tratamiento.
Yeah, I can tell you, of course. I think I didn't have a simple tumor prepared right now, more the ones that really responded to chemoradiotherapy, but I can show one of those. Share the screen. There you go. This is the one. Yes. No, so if you and I'll just jump a bit to a video rather than diving into literature, etc. But I think one of the major things is that you, and I'm focusing here on a T4B, but it's the same principle. If you do this robotically, as we do, you can see very detailed your margins. And this is one, and as I just told you, when there's a real involvement to the bronchus or something else, you really need chemoradiotherapy to downscale it. And we look at it, use endobronchial ultrasound as well, and then resect it using robot-assisted surgery. So what you see here is the patient's trachea, and step by step, I'm taking the tumor that was previously involved, and you can still see it here, that it's whitish and it's really infiltrated. And we're preparing it of the membranous part of the trachea there. So we're really step by step going through the plane that we know that was previously involved with tumor. So we step by step peel it off and make sure that we get it rid. And here you can clearly see the right main bronchus. This is, And I hope you can also see my arrow. And here is the trachea, and this is where the tumor was. And like this, we step by step peel it off the trachea, and the membranous part is totally retracted upward. But like this, step by step, you will be able to clear it off. And we do this for, of course, also for the T2 and T3, but then this plane, of course, will be a lot easier, and not like this, because this is, if you really have that involvement, it will be stuck there, and you really have to be very cautious to get it off, and not damaging the tracheobronchial tree. And I think the robot really helps in that, because you can zoom in much more. You do a microscopic dissection, fiber by fiber. You take the esophagus of the bronchus, and it's nice that you can see even the bulging of the double lumen tube here. Big node as well over there. And that's the way we would approach it. And also the one you just showed, a T1, what we would do is an Ivor Lewis procedure. So we do a robotic abdomen, then go to the chest, and then make sure that we make an anastomosis outside of the radiation field. And we do that in the chest with a hand-sewn anastomosis. I would love to show that if there's time, but let me know what you expect, Alex, to make it a bit interactive.
No, dale, Jelle, mostranos,
Sí, sí.
mostranos el procedimiento completo y tu experiencia con los beneficios de la cirugía robótica.
Okay, I miss a bit the interpreter, but it wasn't. Okay, thanks. But I'll show you. This is another video that is also nice, I think, about how you can reach the upper mediastinum. It's also a patient after neoadjuvant therapy with nodes that involve the upper mediastinum. And it doesn't run that smoothly, but now it goes. And you're here at the cava superior. And like this, you can just really detailed move there and move in this area to clear this whole paratracheal lymph node chain. And I think it's wonderful how, once again, with a very zoomed in image, you can see the side of the trachea there, and then goes on. And I'll show you how this progresses. The edge of the cava again, and then there's the vagus nerve that we totally freed here with the recurrent nerve as well. And like this, you go all the way into the neck, and make sure that you have the whole chain of lymph nodes taken out of the chest. I think that's an important thing. If you do surgery, you want it to be good surgery, and you don't want to leave tumor behind. So especially if there's a PET positive node in this area, I go all the way to get all these nodes out, and to make sure that you really have the whole chain. And the good thing is that this is, of course, a procedure where you would go to the neck if those nodes are really involved, and you want to that they were also in the radiation field. So my anastomosis would be up in the neck. And if you do it like this, your neck dissection is already done when you get there. So it's all exposed already. So that's really a benefit also of approaching it like this. And step by step, you create this space and get all those nodes out. Esophagus is here, trachea is down there, and the cava is here. And I'm always enjoying this very much because it's easy. If I do this open or minimally invasive, I really struggle because it's deep. Your instruments are close together. You work parallel. But robotic, it's like a walk in the park. It's really very easy to approach this area, and that's what I always like a lot in these procedures. And that's of course different than the one you showed me, and I'll stop this one. That is another T4. I might come back to it later, because the one you showed me, I would do an Ivor Lewis. And with an Ivor Lewis, I would do an intrathoracic anastomosis, and I prepare the anastomosis. I fix the mucosa to the serosal layer, to the muscular layer, and then bring the conduit up. And then you see here the stump of the esophagus, and I suture, and I make sure that I take both layers of the esophagus, and then suture it end to side to the conduit. Do it with a V-log 4.0 wire. So it's a thin and not that aggressive wire. And like this, single layer, inside out, outside in, and then I finish the posterior wall like this. Past the nasogastric tube. And before I do that, I place some anti-traction sutures, some sutures to release traction on the anastomosis itself. Sort of buttress or sleep well stitch, as my colleague calls it. And like this, you get the traction of the anastomosis, and then with the second V-log, I close the anterior side. Actually, I just finished the case, and this looks exactly the same as what I did today. So it's very reproducible. It's pretty easy, and it's not a difficult or risky step. We had to learn this, of course, and we had some leaks when we first started this, and now we have a very low number. It's below 5% of leaks from this anastomosis. And also here at the anterior side, I make sure that I lock my V-lock. That's step one. And then I do a couple of those traction release sutures. In general, it's four of them. And it really covers the whole anastomosis like this. This is one of those. So full thickness stitch that you cover your anastomosis and release the traction on it. I love this slide knot. You really very controlled bring everything down, and then I finish with a omentoplasty. So that's what I would do in this case, and I can stop it right here. I'll stop the sharing so you can go on and.
Si querés, Jelle, antes de pasar a la resolución del caso, mostrarnos un poco cuál vos crees que son los beneficios con la estadística que ustedes tienen o la literatura de la cirugía robótica sobre la mininvasiva, si es que hay algo, o bueno, claramente sobre la cirugía convencional, ¿no?
Yeah, so that's great. So there is a lot of evidence, at least more and more evidence about robotic surgery, and I'll bring back that presentation, and I'll move up a bit in the presentation, because there are more and more papers coming out, and the first one, and this is comparing robot-assisted esophagectomy versus minimally invasive esophagectomy is your question. What we did in our own hospital is comparing robot-assisted to open surgery. So there was a trial that we did a couple of years ago, and what we found, we operated 54 and 55 patients in each group, and we found a lower percentage of postoperative complications in general. So, but that was mainly caused by a lower percentage of pneumonias, so of cardiopulmonary complications. Also a lower percentage of atrial fibrillation. And now that we follow it up a bit longer, we have less postoperative pain. So the postoperative, the thoracotomy syndrome is really causing a lot of pain for some patients. And we even find a better quality of life. And oncologically, it was fully comparable. But of course, the more recent discussion is robotic surgery better than a standard minimally invasive procedure? And And there have been some recent studies in that. So I have a bit of literature overview for you. So this is a trial from Zhigang Li, who's a great guy and works in the Shanghai Chest Hospital. And they randomized and published in the Annals of Surgery robot-assisted versus minimally invasive, 360 patients. They did it in a bit over a year. So that's pretty cool. That hospital operates 2,000 esophageectomies every year. So next time, make sure that we will bring him to Buenos Aires, Alex. That's a great guy to have around. And what they found is that they are faster with robots. They have an equal blood loss and equal conversions. That's for the intraoperative. And postoperatively, they managed them all very aggressively with early mobilization, and they didn't find any differences. So that's their randomized trial. But if you look at the not head-to-head comparisons, you'll find some advantages of robot-assisted procedures. So this is the first one published last year. These are mainly cohort studies, and they included 60 studies with over 6,000 patients. And of course, most of them were conventional MIEs and only a few robotic. And what they said is a longer operating time, but still a reduced blood loss and lower morbidity in this head-to-head comparison, mainly caused by a lower rate of pneumonias. Equal lymph node yield and equal R0 resections. And there are two more like this. So this is one from a Chinese group. They only looked at comparative studies, found 14 studies with almost 3,000 patients that were equally divided between groups. So that's a nice head-to-head comparison, I think. And what they saw was, again, a longer operating time, a lower pneumonia rate. But this is interesting. In China, they do a lot of upper mediastinal dissections, and they found a lower recurrent nerve injury rate. And that's interesting. I think you can do more precise dissection amongst this recurrent nerve. And they found an equal overall complication rate. And there's one last. This is the last thing I'm going to tell you about literature. And they also did a meta-analysis of comparative studies, found 23 with 11,700 patients. And there was a good division with a lot of RAMI cases. And once again, they found a lower rate of pneumonia. So that's an interesting thing that is pretty consistent. And they found, a bit different from the other studies, but they found a higher number of lymph nodes dissected. And I think that's something that I recognize from my own series, that I do a better lymphadenectomy, as I just showed a bit, I think, in that movie that I showed. And the other outcomes were equal. So that's a bit what I wanted to say about evidence, Alex.
Buenísimo, gracias Jelle, y por ahí dejamos después para los panelistas charlar un poco más de por qué hay menos neumonía, ¿no? Porque es como, no es muy intuitivo que los dos son mininvasivos, pero parece bastante consistente en todos los hallazgos, así que lo dejamos para el debate. Entonces vamos a tomar que Jelle hizo el caso y lo hizo muy bien, pero como siempre pasa alguna vez, cuando vamos al otro día a ver el paciente, la frecuencia cardíaca, que era de 70 en el postoperatorio, ahora está en 95. La proteína, la C reactiva, ahora está en 18. El paciente no tuvo fiebre, pero está ahí, no tiene glóbulos blancos. Nosotros eso lo tomamos como un gran signo de alarma, y en general rápidamente actuamos y le hacemos una endoscopía, y en la endoscopía uno ve que la anastomosis, si bien no se ve ningún agujero, hay una zona que está menos irrigada, que no tiene la misma salubridad que el resto del tejido, y que coincidiendo con el hallazgo de de la frecuencia cardíaca nos pone en alerta. Entonces, Félix, la primera pregunta es, ante un hallazgo como este, ¿qué relevancia le dan al delta de frecuencia cardíaca? ¿Qué relevancia le dan a la PCR? ¿Y cuáles son sus primeros pasos ante estos hallazgos?
Yes, so I share my screen first. Right, and I would jump to the correct slide. All right, first of all, thank you very much for having me here. And I'm eager to hopefully sufficiently answer your questions. So I have put a couple of information about our protocol following Ramirez in our institution on this slide. And the very last sentence would apply best to what you have asked. So we have a standard lab on postoperative day 1, 3, 5, and 7, so every 2 days, more or less. And in this situation that you have described, we would probably not start with the endoscopy, we would start with a CT scan. However, if we had started with an endoscopy as you showed, we would then do a CT scan. And if we detect a leakage in that CT scan, we probably would go back to endoscopy and start endoscopic treatment. The heart rate certainly is just some sign that there is something in the patient wrong. But of course, if you just see that anastomosis without a CT scan, it could also be pneumonia, also other complication that is even more frequently seen after esophageectomy than the leakage. However, the anastomosis looked suspicious as I've understood you. So probably if the CT scan then shows a leakage in the oral contrast, we would start endoscopic treatment. So the question is, of course, how do you start it? So I brought 2 pictures as well that would everybody understand that we have one case, there is a large cavity, and the other case, which is a little bit more similar to your presentation, which has only a very small fistula or a small leakage. And so before planning the endoscopic treatment, we have to know more about how large is the defect, what is the perfusion of the gastric conduit, and what is the condition of the patient, and is there an abscess behind this leakage. So this applies to some of the information that you already gave, but this is more or less how we would react in this situation.
Perfecto. Y puntualmente el tema de los antibióticos, en general uno encuentra resistencia cuando no hay una fístula clara, pero hay sospecha. Uno sabe que con la terapia antibiótica temprana, la gran mayoría de esos casos se resuelve incluso sin endovac. Pero si no está protocolizado, muchas veces hay resistencia desde el punto de vista infectológico para el comienzo temprano de antibióticos. ¿Eso es algo que ustedes ponen de rutina?
Yes, so this would be probably the first thing that we do even before we go to the diagnostics. We would apply antibiotics to the patient because it is very, let's say it this way, it's very unlikely that this patient suffers from a condition that doesn't need antibiotic treatment. So it's very likely whatever that patient suffers from, antibiotic treatment is part of the therapy. And also, as you have also seen probably in your patients, during the process of endoscopy or the oral contrast and the CT scan, and they have to lay down, there can be another incident of aspiration or septic condition of the patient. So this is something which is
very much evidence-based that early administration of antibiotics in this kind of situation is sometimes even life-saving for the patient.
Excelente. Y si el paciente tiene entonces una cavidad como esta, perdón, gracias ahí, Ornella.
You may share your screen now.
Ahí ven, ¿no? Ahí, esto es una cavidad grande, como mostraste en uno de tus casos, en el que nosotros ahí ponemos el endovac y después vemos cómo resolvemos, porque generalmente estas cavidades grandes tardan más tiempo en resolver.
No se ve, Ale.
No se está presentando.
No se ve la imagen.
Perdón, no, ahí terminó el video. Igual voy a detener el sharing para pasarle a Felix. O le podemos pasar
Tenés que compartir vos, Ale, porque no se vio el video.
Ok. Perdón. Vamos a ver. Esperen que... Perdón. Acá. Déjenme compartir. Y vamos a compartir ahí. Ok. ¿Ahí se ve?
Ahí se ve perfecto.
Ok. Félix, entonces, en una cavidad así que es muy grande, donde el antibiótico solo obviamente no va a funcionar, nosotros hacemos endovac y por ahí lo combinamos con algo más. Nos gustaría ver cuál es el protocolo que tienen, que ustedes tienen muchísima experiencia y son uno de los pioneros en la terapia de endovac en el mundo.
Yes, so I was suspecting that you show a case like this, so I have a similar picture. It's like a Rocky Horror Picture Show that we have for this kind of thing. So if you can see my screen, you can see a similar case with a very large cavity. And you can see what we did is we applied the endovac in the cavity. So this is not I mean, this is what we do. This is what people do. And I think this is where the endovac applies best and is probably superior to other endoscopic treatments, as it is also able to a little bit wash out the cavity and clean the cavity. And you can see in this same case, later on, it looks like this, and you can see that even a large cavity can really heal when the endovac is applied. And this patient goes home well. And this patient, I remember because it's one patient from this year, he has never seen the ICU during the treatment, which is most important. And we probably forgot to mention on the first side that I think one of the most important factors is that we detect the leakage very early. So whenever there is something wrong with the patient, we have to react immediately. We need to have CT scan 24 hours a day. We need to have endoscopy 24 hours a day, more or less, to be able to keep the patient in a stable condition. And if we, even the large leak, if we treat it very early, I think we can most of the time keep the patient on the normal ward without any sepsis, and then treat it successfully. What you are referring to is probably also the SOS treatment that we also apply. So it's SOS for stent over sponge, which is a very nice treatment for this kind of leakage after a while, I think. So at first we want to get rid of the very dirty stuff and the abscess. So for this, the evacuation and maybe a little bit having it open and let it be sucked out by the endovac is most important. But after a while, of course, we also want to have the patient to have oral feeding or something. So how we can achieve it, even if there is still a large defect that we know is going to heal, but it takes some time. So in this case, you can after a few cycles of endovac, probably you can apply the SOS, the stent over sponge, and then you have the option. You have two cavities. You have the original lumen of the esophagus and the conduit, and then you have the cavity which is separated from the original lumen, and you can start oral feeding, which is a big advantage.
Y Félix, eso es, nosotros también ahora hacemos como una terapia combinada, primero el endovac y después lo llamamos terapia de postas o relay therapy, porque primero hacemos el endovac y cuando está resuelto ponemos el stent, pero tengo ahora entendido por la industria que hay un dispositivo que nos va a permitir hacer ambas cosas en simultáneo, y también tengo entendido que han sido uno de los primeros, si no los primeros en el mundo en probarlo, así que si querés contarnos algo.
Sure. What you are referring to now is the endovac. So the vac stent, which is combining the endovac and the stent to try to have the benefits of both. So before showing you, I mean, you see the picture and you will understand the concept immediately. Before I jump to this, I want to a little bit show one slide to understand the history of how it got there better. So the stent is a very well-known therapy that had been there for a long time. And then maybe for 10 years internationally, the EVT is used. We started in Cologne to make it ourselves more like 15 years ago. And then there was a product and we thought it's good. And so then we had two options routinely, and we had to decide which option to take. And of course, if you have a large cavity, like in the case, you would probably prefer the EVT so the endovac to evacuate it. If you have a small defect and no abscess behind it, you might apply a stent because you can have oral feeding. You can even send the patient home. I think what we also learned is that you can do the endovac first and then the stent, and then send the patient home and then see him after 5 weeks, which is also a nice treatment. And so I have taken together the possible pros and cons of the EVT and the stent. So you can see it on this slide. And in Germany, I don't know how it is in other countries, but in Germany, we have to say that the stent has some extra reimbursement and the EVT has not. So we have to face the fact that the EVT, the endovac, is a much more expensive treatment rather than the stent, which is a problem somehow because we do not get a good reimbursement for the EVT. And as I worked together in Cologne together with Peter Grimminger and others, we had a very large series of patients, of course, for esopagectomy. It's a very, very large center. And over the years, we gathered many patients, like 1,500 esopagectomies. And then, of course, you also have the leakage cases. And we compared, after a while, we compared the endovac and the stent treatment. And so we had 76 patients with a stent, and because the endovac is a little bit was introduced later, we had a lower number of patients. So we found a success rate for the EVT only for 85% and a success rate of 72% only for the stent. Of course, this is retrospective, and it was very difficult to evaluate, because sometimes you would change the treatment strategy because you do the stent, it's not working, then you change to the endovac, which was counted as a failure of the treatment. That's why you have 72% and 85%, and not all other patients died, of course, but you had to make a change of the treatment in order to have a successful treatment in the end. But this difference was not significant, which was a little bit surprising, because we thought, yes, clearly the EVT will be superior, but if you take these numbers for, let's say, designing a prospective randomized trial, you will see that there is a almost 15% difference. So we believe maybe the Endovac is a little bit superior, but has its flaws for the oral feeding. And now I finally come to the device that you are referring to. So naturally, it was thought to not have both devices in the SOS treatment, but in one device, the VAC stent, which is now a product which is available in Germany. It's very new. It's a little bit more than a prototype, I would say, and we would also use it in patients. And I would like to show it to you how it looked like in a leakage like this. The pictures are not perfect, but this is how I got it. We don't have a high number of patients because it's just in the beginning. So you have a leakage. You think you can cover it with a stent, and then you have in the middle you have the VAC, and you can evacuate the dirty material behind it. I think the concept of this device is very interesting, and it perfectly combines the benefits of both treatments. However, I have to say we are not the first in the world to have used it. So the owner of the patent had a couple of patients, like 8, and showed a great success. Then another clinic in Germany evaluated 20 cases, and the success rate was only 60%. But I'm not worried about the success rate, because this is a little bit subjective. Because when do we stop this treatment and use another one? This is highly subjective. So I think if you went on and on and on with this treatment, maybe you have a higher success rate. But what we also found in the cases that we had, that the oral feeding would not be so successful as we wish to, because the Endovac, the suction would also suck on the fluid that we give and on the food, and it would also lead to a clotting of this device sometimes. So we really like this device, and we want this device to be, further developed. I'm not sure if this is the ultimate solution for all our leakages, but I think it is definitely one of the future perspectives that we have for the treatment.
Buenísimo, buenísimo. Sí, claramente sabemos que en esta cirugía ninguna herramienta por sí sola soluciona nada y se requiere un equipo entero. Así que me parece que con estas dos clarísimas exposiciones e introducciones de cómo operarlo y cómo resolverlo cuando se complica, Alfredo, te paso de nuevo la posta para empezar a preguntas más puntuales que tenga el panel y tratar de sacar la discusión más fructífera posible sobre la experiencia de cada uno.
Muchas gracias, Felix, y muchas gracias, Jelle. Bueno, los invito a Mauricio y a Ramirez y a Fernando Wright si quieren dar introducción a la sesión de preguntas y comentarios al respecto. Mauricio.
Hola, buenas tardes a todos. Gracias, muchas gracias, Jelle, y muchas gracias, Felix, por la presentación, por la participación. La verdad es que hay muchas preguntas para hacer, pero bueno, algunas a fines prácticos. Quería preguntarle a Felix, en el tratamiento del Endovac, si tienen algún protocolo de manejo en cuanto a las presiones, con el cual manejan la sonda colocada. Si tienen preferencia, porque veo con en las imágenes hay esponja, si tienen experiencia tanto con esponja como con sin esponja, y si tienen experiencia en mandar a los pacientes a la casa con estos dispositivos de presión, digamos, de ejercer presión ambulatoria, y qué es lo que habitualmente usan.
Okay, these are a lot of questions. I hope I catch all of them. So first of all, I think you were referring to the pressure that we apply to the Endovac, right? So if we have an electronic device, you can apply something like 60 millimeter HG. I'm not sure how is it in English. But I think, I know we before we used the electronic pumps, we would use a certain vacuum drain, a simple vacuum drain to be connected to the tube. And we also investigated how high is the pressure, and it is somehow higher. And we got a little scared and found little tricks to reduce the pressure. I think you know what I'm talking about. But I think, and I'm talking to other endoscopists in Germany frequently about this. Until now, there is no clear evidence which is the optimal pressure for the endovac. And I think what is just important that there is a negative pressure, and it should be checked frequently. So the pressure should be there, and the tube should not be clotted. And our protocol is to change it every 3 to 4 days endoscopically, or if the pressure is gone, earlier. So this was one question, I think. Please go ahead with another one. I want to answer it in a good way.
Muchas gracias por la respuesta. Sí, la verdad que para nosotros también es difícil encontrar el punto exacto de aspiración, digamos. Sí tenemos como parámetro al momento de colocar la sonda que al salir de la cavidad esté colapsada la cavidad por la presión antes de salir. Eso como un tip. Y la otra pregunta era si mandan a la casa a los pacientes con el endovac colocado y con algún sistema ambulatorio de aspiración.
No, we don't send any patients home with the endovac therapy. This is one of the maybe disadvantages of the endovac therapy. I know in the US people or doctors do it. We don't. We do send patients home with a stent. We don't send patients home with endovac.
Puedo agregar ahí una pregunta, justo el doctor Wright, no sé si está justo con buena conexión, me estoy comunicando con él. Quería saber si con la técnica del endovac la mayoría de las veces pueden evitar el hecho de hacer una videotoracoscopía, son VATS, o sea, les permite, tomado tiempo, evitar un VATS, el hecho de hacer un endovac, o en algunas circunstancias también lo requieren o lo hacen en simultáneo. ¿Cómo lo manejan?
So reoperation, which that would be, is a very rare incident in our institution for the treatment of anastomotic leakage. Very rare. So the reason is maybe because those kind of therapies work out in a very good way. Secondly, you are referring to the situation where an abscess is not sufficiently drained by the endovac, which can happen. In those cases, we would prefer to have a CT-guided drain and not a reoperation. So the only situation in which we go for reoperation is if the patient has an uncontrollable sepsis due to mediastinitis, and it is just a matter of very, very short time that it's a life-threatening situation and you have to resolve it now. This might be the only situation in which we apply reoperation, and in all of the cases, and the case maybe that you are referring to, we would prefer a CT-guided drain rather than a toracoscopy.
Ok, muchas gracias. Matías, Miura, sí, escucho.
Y él levantó la mano.
Perdón.
Yeah, I think that you have to make a difference between a contained leak and a non-contained leak. So if you have a leak that is contained and there really is a cavity and that's the only presentation of the leak, then you might offer a good solution with endoluminal therapy. I'm not sure if you really need a vac for it or you just need a sucking nasogastric tube. That might also be a good solution. I don't know the exact effect of that sponge, but I think if you suck and drain the fluids, if it's contained, it's fine. But if a leak is not contained to that area, so it leaks into the chest, you need to do it, a thoracoscopy to clear it out. And usually those fluids are not really fluid, but there's a lot of debris in it and septi. And so I think in those circumstances, I would definitely do a VATS. And I would regret not doing it. Because if you're early, you combine a VATS with a stent, the patient is up and running within a couple of days. So I think that's something you shouldn't just strive for an endoluminal therapy only. I think you should really look at the patient, look at the CT scan, and see where your collections are. Just to add on what Felix is saying.
I would also support that any collection intrathoracic should be evacuated as soon as possible. And whatever it takes is the correct way. So just from our experience, the reoperation is quite rarely seen to be necessary. But I'm not saying that it's due to the endovac, because I know other clinics are treating the leakage very successfully just with a nasogastric tube. It's absolutely possible, and the same principle. But it might also refer to the fact that we have very experienced radiologists for the CT-guided drainage. And if most of the leakages are so early that we still have a thoracic drain inside, very close to the field where the problem is, and it is another option to drain. But I totally agree. If there is a collection anywhere and you have not sufficiently drained it through the endoluminal therapy, you need to drain it in another way. Yes.
Perfecto, muchas gracias. Doctor Matías Miura, ¿tiene alguna pregunta para los expositores?
Sí, ¿qué tal? Buenas tardes. Bueno, muchas gracias y felicitaciones a los dos expositores. La verdad que clarísimo los conceptos que nos han dado. Nosotros también hacemos tratamiento de fístulas con endovac y stent, y también utilizamos terapia combinada. Mi pregunta va para Felix, para el doctor Berlth. En cuanto a la terapia combinada, nosotros la dificultad que encontramos es más bien en cuanto a los costos, en el recambio de la esponja y el stent. Eso, por lo menos en Argentina, eleva mucho los costos del tratamiento. Mi pregunta es, ¿qué indicaciones tienen para la terapia combinada stent y endovac? ¿Y cómo hacen con el recambio de la esponja y el recambio de los stent? ¿Cómo manejan esa dinámica en el día a día? Y con última pregunta con respecto al back stent, también, si eso es, no sé si lo has dicho, pero si eso se pone y se deja, o también necesita recambio cada 3-4 días.
Very good question, very important question. So the SOS treatment that you were referring to first, yes, it's a very costly treatment, and so the only advantage is that we do not have to change the stent every time. So after 3 or 4 days, we would push the stent down, get out the EVT, put in a new one, and pull it in the right location. So it is a EVT treatment plus 1 stent in the optimal way. Yes, it is more expensive, but it is reserved for cases with a large cavity that we think it takes a long time, and we do not routinely, for instance, put a uronostomy. So if we know that the leakage treatment will take a lot of time, we also have to face the question, how are we going to feed the patient? And if the patient is in a very good condition and the risk of aspiration or so is not so high because the patient is relatively fit, I think then combined with a large cavity, the SOS treatment is a good thing to do, to just make it possible that the patient drinks some high caloric drinks, and it is good for the wound healing itself. Talking about the back stent device, this is also a very important question that I have not addressed at the first time. So it is very expensive. So the device, I think it costs 1,500 euros here in Germany now, and you have to change it every time. So it's very expensive treatment. And this is, I think, the main reason why it is not yet routinely used everywhere. So we were one of the first to use it, and our endoscopists already complained about the costs of the treatment because, yeah, if you have to change it every time, then you cannot afford more than 2 or maybe 3 cycles, or you want to have the leak sealed within 1 cycle, then you can only apply it in very, very tiny holes maybe, and then the advantage of the VAC stent is maybe not there, because for 1 cycle you don't have to worry about the oral feeding. So this is something that we discussed with the new device. On the other hand, I still want to say that, of course, it makes totally sense to combine the both benefits out of the stent and the VAC. And I think it's a matter of time and a matter of technical developments to have a product that is really getting the best out of both treatments.
Muchas gracias.
Muchas gracias, Felix. Doctor Iturralde, Argerich, Javier.
¿Ahí se me escucha?
Sí, sí, se escucha.
Bueno, primero felicitar a todos los expositores. La verdad que han mostrado casos realmente muy interesantes, el tipo de tratamiento que está instaurando, por lo menos en lo que es en la técnica de Ivor Lewis. Y por ahí yo les voy a traer una contracara, que esto es una realidad. Ver todos estos casos que ustedes presentaron, por lo menos para mí, es algo, digamos, poco frecuente o que utilizamos muy poco, y por ahí parte de eso pasa porque nosotros no hacemos Ivor Lewis, hacemos Maquión. Hay que recordar que por lo menos en la última revisión internacional en la discisiones de esófagus, todavía en la técnica mininvasiva, todavía más del 50% la anastomosis la se hace a nivel cervical y no intratorácica, por más que hay una tendencia mundial de ir hacia la Ivor Lewis. Y mucho de esto, ustedes bien lo saben, es justamente por la complejidad que uno necesita en las 24 horas del día, como bien lo dijo Felix, para tener acceso a la tomografía, acceso al stent rápido, acceso al drenaje rápido torácico, que a veces no todos los grupos o equipos quirúrgicos tienen esa facilidad en su institución, ni los recursos en la institución de otros servicios para poder darle respuesta a una complicación de una fístula o una filtración de una anastomosis intratorácica. Entonces, el maquión, en nuestro caso, nosotros hacemos digamos, la técnica en decúbito prono, hacemos la toracoscopía en decúbito prono, hacemos toda la disección con un vaciamiento estándar extendido, y hacemos técnica, la mayoría de las veces técnica híbrida, y esto porque porque el manejo abdominal del tubo que necesita ir al cuello, a veces tiene que ser un poco más receloso, un poco más perfecto para la irrigación a nivel del cuello, que el estómago, digamos, la punta del estómago tiene que ser, digamos, más perfecta que cuando uno hace el Ivor Lewis, que digamos, usa un estómago prácticamente a la mitad o en un tercio del tubo gástrico. Entonces, le voy a decir, no es tan frecuente porque nosotros con los años de experiencia dejamos esófagos muy cortos, 2 o 3 centímetros de esófago a nivel cervical, y la mayoría de nuestras fístulas que nosotros tenemos, a diferencia de lo que se ha presentado en un comparativo score match analysis, el grupo de Holanda, que ellos presentaron casi un 23% de fístulas con grado 2 de low, nosotros tenemos un 11-12% nada más de fístulas cervicales, y la gran mayoría no tenemos que hacer absolutamente nada, porque digamos, al abrir la incisión se dirigen hacia afuera porque dejamos un esófago muy, muy corto. Lo que sí quiero comentar, vamos, esa es una, vamos, quería preguntarles, porque yo sé que ustedes muchos hacen Evolúes, pero también hicieron mucho maquión mucho tiempo, si usaban este tipo de implementaciones cuando tienen fístulas en el cuello. Y lo otro es, que para mí es lo más catastrófico que le puede pasar a un cirujano de esófago, es que a nosotros me ha pasado en 2 casos, que es cuando usábamos suturas mecánicas, ahora hacemos, para la anastomosis, ahora hacemos suturas manuales, ¿sí? Bien al estilo con más se hace en Corea o en Japón. Cuando tienen la fístula esófago traqueal, que es una fístula extremadamente compleja, ¿cómo la resuelven? Yo tuve 2 casos y fue, la verdad, pacientes muy, muy complejo de resolver.
It's a very interesting question that you bring up, and I think the debate hasn't sorted out if a neck anastomosis or a chest anastomosis is the best one. I'm very sure that a chest anastomosis is more difficult than a neck one. That's one thing I know, and I think that a lot of these leak rates are learning curve leak rates that we look at. So I think that if you master the learning curve, then your leak rates will be much lower, and I think they can be well under 10%, maybe under 5% as we have currently. And I think that you can never reproduce that in a neck anastomosis. I did hundreds of neck anastomosis, really hundreds, and my best year it was 15%, 1.5, and there were years that it was 20-25%. So, and I think we just had this Dutch study that you refer to, and it's this one. I'll show it to you. It's this study where we looked at it. It's published last year in JAMA Surgery, 130 versus 130, and this is in real high volume centers. They all do over 50, 60 esophagectomies a year. And what they found is 12 versus 34% leak rates. And I think that, well, 34 is really unacceptable anymore. So I think if you can go to the chest, I would also always do it because the leak rate is simply lower. But of course you cannot always, because you have these high tumors, you have radiation fields that go up into the neck. And I avoid placing my anastomosis in a radiation field. So if a tumor is high up, I will go to the neck. And in our experience, it's about 60-40%, maybe 50-50, and with a bit more than half into the chest, I would say. And the rest is still in the neck, and we still have like a 20% leak rate there. And the good thing is that they are usually very easy to treat, because you open the neck, maybe put a drain in, but that's it. So, and that's also a bit dependent on how rigorous your lymph node dissection is in the chest. So if you do a real good lymph node dissection in the upper mediastinum, the leak will go bum in rather than out. So that's the easiest way for the leak to present itself. So, and then you have almost the same situation as with an Ivor Lewis. And then there's one more thing. If you don't drain it well, you will get that fistula. And I had one recently. I didn't operate the patient myself, luckily, but a very experienced colleague of mine did. And there was a leak, and we treated the leak with an Endovac. And 2 days after we started the Endovac treatment, we had an airway fistula. And I don't say that there's a causal relationship, but that's why we're not that fond of Endovac too much. Not too much. I don't think it's the golden bullet. I think you have to be very selective with it. And if you have an augmentoplasty, yes, then it's safe because there's healthy tissue between the trachea and the leak. So then I think you can do it. But and if you have a leak, we reoperate. If you have a fistula, I mean, to the airway, then we do reoperate. We try to find a plane between the gastric conduit and the airway, and then close the airway with a bovine pericardium patch. Very often the patient needs to be on the extracorporeal membrane oxygenation, so it's really difficult surgery. Yeah, they're really in trouble, those patients. I fully agree, but we have limited mortality. I think I only know one patient that died after such a re-intervention, but you very often have to go back in because it's usually in an irradiated field. You suture that patch in, but then it starts leaking again. The patient's always on the ventilator, so there's always a positive pressure on that patch. So it's really a tough time for the whole team actually. But you can manage, and I think the ECMO in the post-operative period is really helpful because you can lower the ventilatory pressures and you can protect the patch a bit more. So I think that's my answer to your question.
Felix?
Yes, I can also add that the airway fistula is one of the worst and hopefully rarely seen complication. And we have one publication from the Cologne database, which was quite large, and it showed that 100% of the airway fistulas had an anastomotic leakage. So I think this is everybody's experience, and it supports what Jelle said. You need to drain the leakage right away, otherwise there might be a problem. In the last in the time that I've been here in Mainz, I think we had 2 patients with the airway problem. One was treated likewise as Jelle described. Also, patient was on the ECMO. Critical situation, horrible complication, but he went home. The other patient was luckily stable and not on the ventilation, which of course is saving because of the better pressure condition. And we would explore the patient surgically and repair the trachea primarily just with the suturing, and put a muscular cutaneous flap in between the anastomotic region and the bifurcation, more or less, and it worked out very well. The esophagus was having a complex injury there, and it needed to be reconstructed as well, but it worked out. But of course, these are only cases that we can report, and I'm not saying this is the ultimate way to treat such a complication. I think the best is to get away the patient from the ventilation if possible. You need to force your ICU to extubate the patient if there is any chance, any time window of time where you can do so, and then you don't need to miss the time window in which you go for reoperation. And we have a different proportion of neck and intrathoracic anastomosis. Referring to your first question, quickly I want to answer. So I'm not sure about the numbers, but I guess we have a percentage of 90% Ivor Lewis and 10% neck anastomosis. It's a little bit about our school, where we come from and how we were taught to treat the cases. We do not go to the neck if we have a patient with radiation. But of course, the tumor drives us to go to the neck sometimes, yes. And then there is no other option, and there is no good option other than to go to the neck. But as soon as we can have an intrathoracic anastomosis, we perform it. And I think I understand your doubts about it, and also the complication treatment. And I see that you treat your leaks in a very easy way when you have the anastomosis in the neck. But I'm also worried about the consequences afterwards. So those patients would maybe have a dysphagia or a stenosis, and this is also one good reason to make the operation, because there is a dysphagia and a stenosis. And then you have this operation, you have a leakage, the patient is not septic, but then you treat a stenosis again, which is also not a good thing to do. I mean, there are pros and cons for any technique. We are more going for the intrathoracic anastomosis, but certainly I understand all the arguments for neck anastomosis.
Muchas gracias, Felix y Jelle, por los comentarios. Doctor Fernando Wright, ¿querías hacer algún comentario al respecto, alguna pregunta?
Con respecto al Endovac, nosotros no tenemos mucha experiencia en el uso de este equipo, pero quería que nos comenten un poco el tema de experiencia en cuanto a complicaciones del tratamiento y de si creen alguna contraindicación, ¿sí?, formal del método como para usarlo.
So no clear contraindication, no red line, but I'm referring to what Jelle said before. If you have the suspicion that a very delicate structure is right beneath the anastomosis or the leakage or the area where you want to put the endovac, then you need to be very careful. But this applies to everything that you put inside this leakage. It applies also to a stent, and our data shows, and also other people's data show, that the stent therapy has more complications. I think there is more fraction on the gastric conduit, and it's a very sensitive structure, as you know. I think honestly the most frequent complication is that in the end the endovac is not remained in the location where you put it, and this is happening if you put it intraluminal and not in the cavity. If the cavity is small and you put it in the lumen, then sometimes either the patient removes it a little bit, or maybe during endoscopy, or the patient coughs, there is a little bit of dislocation of the endovac. And then after 3 days, because you don't realize in this moment, after 3 days you see that there is a nice granulation just next to the location where you want to have the granulation, right? So this is I call this a complication, because it's not what we really want to do with this therapy. And but it's not dangerous per se, because if there is something wrong with the patient, you would know. And also, even if you are a little bit more orally with a endovac, still the fluid that comes from below is sucked by the endovac and evacuated. But this happens sometimes, and you need experienced endoscopist and a little bit of feeling for this method to place it in directly where you want to have it.
Bueno, pero hay un concepto que me parece fundamental, que sale de todas estas, de todos estos comentarios, y al que Jelle se refirió en un momento, que es el de la relevancia del parche del epiplón. Nuestra curva de aprendizaje Leibor-Lewis tuvo un periodo en el que no lo hacíamos regladamente y en el que no le dábamos la importancia que tenía que tener, y realmente fue la influencia del grupo de Holanda en el que modificamos la técnica, y la verdad es que para lograr llegar a una tasa a un leak rate debajo del 10%, 6-7%, me parece que el cubrir toda la gastroplastia con el aumento, como lo permite hacer el Leibor-Lewis, es absolutamente fundamental, y además es lo que permite en ese porcentaje de leaks poder hacer el endovac. Entonces me parece que es un punto fundamental y que realmente nadie lo muestra en los videos, queda para el final, y él acá lo mostró, pero en general en los congresos nunca se hace hincapié en eso, y me parece que es un paso súper importante, que ya Miguel Cuesta lo venía pregonando, y que creo que la escuela holandesa lo tiene clarísimo. Y Ela, me gustaría un comentario al respecto, si vos crees que la cirugía robótica permite de alguna manera mejorar la precisión de ese paso tan clave?
I think it does. I think it does. I think what the robot does, and we were just talking a bit about an open abdomen and be more gentle maybe through that. I don't think so. I think with the robot, you're the most precise, most accurate, most gentle that you can be, even though you don't feel anything. And in this way, I can prepare a very nice omentoplasty as well, just following my normal route. And that you can always wrap it around the anastomosis. And I think that that's something that protects the trachea from these fistulas. So I think that that is really helpful. And healthy tissue between the two structures that you don't want to be connected. I think that that's a critical issue, a critical factor to prevent these serious complications.
Muchas gracias, Jelle. Una última pregunta, si así vamos concluyendo.
Felix, levantó la mano, Alfredo.
Perdón, Felix, perdón. Felix.
Yes, if we have the time, I have a video here that shows our technique if you want to see.
Sí, por favor.
Here. Okay. So, can you see it now? I think so, right? So
sí.
I will go. Okay, now I will go to the, oh wait, this is wrong. I don't want to show the whole thoracic part, just the, I think I have to go to this kind of, okay, I will just start. So we use the stapling method. As you see, it's a double speed video, so don't be shocked. And this is our gastric conduit, and we leave, as you see, we leave a lot of the arcade in omentum, even though it's going to be taken away afterwards when we retrieve the specimen. After we shoot the anastomosis, this is our technique, and you see the fat here, which you mentioned before. Now we put it there, and we resect the specimen. Okay. And then we have a circular anastomosis. We use the 28 millimeter circular stapler most of the time. And we do reinforce the anastomosis with barb suture. Same, I think same material as Jelle used for the anastomosis. And we do believe, even though we don't do hand sutured anastomosis, we do believe that this reinforcement is really giving additional benefits. And if not in terms of leakage rate, maybe in terms of leakage rate, but if not, then in terms of how much impact the leakage has on the patient, how big is the defect. And then you can see that we have a pleural tent as well. So we have the pleura, and there the fat goes beyond the gastric conduit, and we wrap and flap it and stitch it to the conduit. So we create an own cavity also for the anastomosis. I think it's a very, probably a similar way that than Jelle is doing it. And I think, yes, also the Dutch group has influenced us in this situation, I believe. So you see that now the whole anastomosis, at least from one side, is covered, and from the other side you have the fatty tissue probably protecting it and giving the space between the airway system and the anastomosis, which also Jelle mentioned before. So this I wanted to show because you were mentioning it.
Muchas gracias, Felix. Muy bueno el video y se ve muy claro cómo queda separada la anastomosis básicamente de la vía aérea, como decía recién Jelle. Una preguntita más y vamos concluyendo. Felix, nos mostrabas ahí una anastomosis mecánica circular de 28 milímetros y Jelle tenés otra técnica con anastomosis manual, y también, bueno, en la historia de la MI también conocemos la anastomosis lateral. Quería saber con respecto puntualmente al tratamiento del stent, si nos pueden hacer un comentario, porque el stent me imagino que podemos aplicarlo de igual manera en una anastomosis, por ejemplo, lateral, o en una manual con respecto a la migración del stent, o la posibilidad de la migración del stent según la técnica anastomótica.
Well, I think migration is not that much of an issue because you have a semi-covered stent with an uncovered proximal part, and that uncovered proximal part will go for the fixation. That's the part that holds it in place. But I'm a bit worried always with this barbed suture, because if you put those radial forces on the barbed suture, I think it might be like a giggly saw almost. And so I'm not that much a fan of stenting in those circumstances. I think with the circular staple, as Felix and Peter Grimminger do, I think it's wonderful and it might hold very well. But with a barbed suture, I'm a bit reluctant. On the other hand, if you already have the leak, you can. We do it sometimes. If you have a ongoing leak, we would use it, but not as a first line treatment.
Ok, entendido. Bueno, si no hay pregunta, Ale, no sé si querías hacer un comentario, si no, bueno, agradecemos la participación realmente de ustedes, Felix y Jelle, bueno, y a todos los panelistas, y un agradecimiento también a la Asociación Argentina por darnos este lugar. Gracias a todos y bueno, damos por concluido el seminario. Está sin audio, Ale, me parece.
Gracias, Jelle y Felix, nuevamente por aceptar la invitación, y a todo el panel, la verdad que fue un placer. Creo que trabajar las dos comisiones en conjunto y combinando lo que es cirugía mininvasiva y endoscopía es algo que tenemos que hacer en el resto de las especialidades, porque hoy ninguno de los dos carriles anda solo, así que vamos a seguir pregonando por estos webinars conjuntos.
Bueno, muchas gracias a todos y bueno, nos despedimos hasta el próximo encuentro. Saludos.
Gracias. Chao, chao.